So now we're going to come up to a couple of cases in which some of these will be illustrated. And Cindy, take it away with the first case.
Sure. Thank you, Jim. So we're going to do an interactive case. So let me just get we're going to start with our case study. Okay, so we're going to start with our first case. So this is a 27-year-old no-pars female who is presenting with epistaxis petechiae bruising and some heavy menstrual bleeding. And at the time of presentation, her platelet count is 5,000. She was started on a 4-day course of dexamethasone, but had no response. And so therefore she was added in some IVIG, and her platelet count did respond to that. She had cessation of her bleeding symptoms as well, but then her platelet count fell back down again. She was then treated with a course of rituximab, which was chosen because of the likelihood of cure in women of childbearing age. But she had, and at that time, she really wasn't having a whole lot of bruising symptoms. And with rituximab, her platelet count did increase to 163,000. And she was able to say, the ITP really at this time is not interfering with my daily activities. So 4 months later, she does present again with a few small bruises and recurrent heavy menses again over the last several weeks, and her platelet count is now back down to 31,000. She returns 2 months later, and previously she was known to be that steroid-resistant patient. She did respond to IVIG, and she did have a kind of short-lived complete remission on rituximab. But now she presents again with bruising and a platelet count of 15,000. So we go back over and we kind of have to, at this point in a patient like this, really reassess where we are with her ITP. Is there additional studies that we need to do? What else do we need to be looking for? Perhaps there's a reason that she's now had a drop in platelet count following rituximab. So an important time point to always come back to that initial evaluation of ITP. So here is a nice diagnostic algorithm that I like that just talks through different pathways of thrombocytopenia and where we might end up. And again, for us, we're in the category of isolated thrombocytopenia, which does lead us to ITP. And in this patient, that remains our diagnosis. So we now have another poll question. So what percentage of adult patients develop persistent ITP, so defined as greater than 3 months, despite first-line treatment, including corticosteroids and IVIG? A, 10%, B, 20%, C, 50%, D, 70%, or E, 90%.
Cindy, one of the things that's amazing to me, we're asking here about persistent at 3 months, but we know so little about how many adults will get better with or without treatment at a year, 2 years, 3 years. It's kind of embarrassing.
Yeah, I think that for adults, right, we don't really know we don't know as much about natural history of untreated patients, right? Because so many patients do get treated up front. So we have a good mix on this one. With our responses that have come in, the majority are about 50% of people are saying 50% of patients. We have a few votes cast for 70%, then 20%, and a vote for the 10%. So let's go back and we'll have this discussion. So 70% is our correct answer. So again, a large number of adults will end up with persistent ITP, another characteristic that makes them different than children, which are less likely. So we are now going to sit down with our patient and have to figure out what to do next, right? And we kind of talk to her and begin to get her story, as Dr. Bussel was telling you. This is about learning the patient story and learning from them. And she says to you, I really didn't like how I felt on steroids. I was unable to sleep. I felt depressed. Rituximab also just really didn't make me feel good on my infusion days. And sometimes I just had to take some time off work to recover. I don't want to be immunosuppressed again. And I really don't like getting shots. And I would just prefer a medication that doesn't have a lot of side effects and allows me to feel my best and to continue working. So which of the following treatment options would you recommend for this patient? A, corticosteroid course again. B, another single dose of rituximab. C, a second course of dexamethasone. D, avatrombopag, or E, I just don't know.
Cindy, if she had
That's
had,
too
if
responsive.
if she didn't dislike rituximab as much as she did, which is sounds way more than average,
Yes.
and she had had a longer response, like a year, might be very reasonable to retreat her with rituximab.
I would
That's
agree.
a lot of ifs.
I don't. Yeah, I agree. This is again where I think hearing that patient story, obviously her experience with rituximab was quite different than a lot of other patients. And, when you talk to her, that's where it's also talking to her more about what exactly were the side effects that she had, to really get a deeper understanding of why she might not want that therapy again. So we have most of our votes are in, and we are looking at the majority, almost 80%, have selected avatrombopag. A few selected a second course of dexamethasone, and then there were actually a few who said they didn't know, which is okay. So back to our slides. So we decided to start her on avatrombopag because listening to her story, this really is the medication that will best achieve her goals and align with what she wants in a therapy. So what next steps would you recommend for this patient? Prescribe a new treatment option, refer her to another hematologist, begin shared decision-making, or send her for a bone marrow test, or I don't know.
So, Cindy, if she had not responded to previous treatments, it might be a little more reasonable to do a bone marrow test, think about another hematologist or a totally new treatment option. But it seems here that she's somebody who's a responder. She just doesn't feel good on the treatments when she gets them. So you're looking for something to make her feel better and help her platelets.
Exactly. And this is where, I look at it as a little bit too of goal setting. What are we trying to achieve with the therapy? What are we trying to achieve outside of just the diagnosis of ITP in our daily lives? So we do have some poll results coming in. So for her, there's a vote for getting that bone marrow test that you talked about, but I agree. She has had a response to some therapies, prescribing a new treatment option. So, this is a little bit of what we were showing in the last slide, but the majority, 80%, selected that shared decision-making. And I think this is really the key of what we're trying to highlight with these cases and with our discussion here today.
Cindy, yeah. Can I just add one thing?
Yeah.
In the shared decision-making, if she said, I don't want to deal anymore, I want a splenectomy, that wouldn't be unreasonable. If she said, oh, I loved a few months with good count and not feeling bad, I want more rituximab, or whatever she said, because of the way the data is, we can't demand that there's a best treatment here, and this is what she has to do. And that's why you had the leukemia option in the beginning, to illustrate how we're much less restrictive and proscribing in it.
Absolutely. This is where I say it truly is the art of medicine, right? We don't have to, we're not bound by a particular protocol or pathway. We really just get to sit and listen to our patient. And oftentimes there is more than one treatment that would be perfectly reasonable, as you highlight. We oftentimes have multiple options that we're considering for a patient. And again, it just comes down to that interactive conversation and goal setting with them and understanding those values and preferences. So we do initiate shared decision-making with her. And again, we come to the conclusion that avatrombopag seems to be the best therapy.
And to be fair, it's the best therapy for her at this time.
Correct. And I do think it's always important to that point. I do think it really is always important to check back in with your patients and make sure that the decision that we made 2 months ago still remains the right treatment and the right decision, right? It's very easy to just start a therapy and let time go by, and we forget to check back in. So this is just a slide highlighting these different therapies, which we've talked about, the different TPOs, rituximab as an option, splenectomy, and then we introduced fostamatinib as well. And this is sort of the category we were in with our patient. She had already received some first-line therapy and was now looking for a second-line option. So this is really outlining kind of the basic conundrum that we've been talking about this whole time that was actually experienced when we tried to make prescriptive guidelines for second-line therapy in adults with ITP. And what we realized is that it's very, very difficult to really put these things side by side. We lack randomized controlled trials. They're so vastly different, right? Comparing splenectomy to 4 courses of rituximab to medications that are ongoing and daily. It's very challenging. And so we ended up in a place where we really felt the most important thing was to assess different characteristics of the patient in terms of how long they've had ITP, maybe what they've responded to in the past, but whether or not they've had chronic ITP, in which case we might be more likely to consider splenectomy, or if it's earlier on in the course. And then what are those values and preferences? And also, is there anything else that might indicate which therapy is best for a particular patient? And this is where we really came down to more of a values and preference-based algorithm, if you may, for second-line therapy as opposed to very, very firm guidelines with very strong recommendations. Because treatment should always be tailored to the patient, and many factors may contribute to patient decisions. And these are all the things that we've already talked about in terms of patient characteristics and values that may impact their decision for treatment. So when we think about second-line therapies, we know that 2/3 of adult patients will develop persistent ITP despite our first-line treatments. We lack randomized controlled trials to put these side by side. It really depends on how well a treatment's efficacy profile and potential side effects really align with our patients' needs, priorities, values, and preferences. And uncertainties demand unbiased information dissemination by patients and clinicians to really empower them. And the American Society of Hematology clinical guidelines would conditionally recommend a TPO rather than rituximab, which is recommended over splenectomy. But in any event, our patient had rituximab already without a long-lasting response. So TPO-RA aligned with her values and preferences and actually seemed like a very reasonable option for both the patient and her treating physician. So what are the benefits, again, of shared decision-making? So with this patient, we engaged in shared decision-making because we wanted to understand her journey with ITP. We wanted to be able to recognize that a decision needs to be made based on the information we have, but then we need to make sure the patient understands pros and cons of those options. They have the information and tools that they need, and they're better prepared to talk to their healthcare providers when they come to the visit and collaborate. This really is a collaboration when there's really no one right specific treatment. And, I think in the end, this makes patients more likely to be adherent to their medications, to feel empowered, and to make the right decisions for them. So in conclusion, how were the patient's preferences acknowledged? Well, again, we know that we don't have biomarkers or reliable evidence to choose a particular therapy. And so in her case, we sat down and we understood that we expressed those uncertainties and we tailored our decision to her based on the information that we had. And our patient really was pretty clear in what she did and did not want. And we were able to listen to that and incorporate that into our decision. And when we looked at our TPOs that were available, we really had avatrombopag and L-thrombopag as oral options. And we chose avatrombopag because it just has a slightly different side effect profile than the L-thrombopag, and that seemed to appeal to our patient. She did not want injections, so we did not do romiplastin, and she had already had rituximab and did not appreciate the way that therapy made her feel. These would all be suitable options, though, as we've talked about, and we engaged in a conversation about each of them from the beginning with her. So again, just highlighting how we arrived at our particular decision with her, and she wanted something that would work well with minimal side effects. We took fostamatinib off. Fostamatinib does have some degree of side effects, although it is an oral medication. And when we talked her through that, she again really favored something that was going to have the lowest possible side effect profile, but with acceptable efficacy as well. And she, in the end, chose the avatrombopag because of all the lack of dietary requirements, as well as, again, we talked about the side effects with the liver. And it just seemed like an easier medication for her to be able to keep up with and fit better with her lifestyle. And she does realize that there's less experience with avatrombopag, but she's really not that concerned about thrombosis. And there may be this increased risk with avatrombopag, although she recognizes it's not very clear. And she's actually okay with that, again, because the rest of it fits what she desires. So I'll stop there. Thank you for joining me on that patient journey.